Coding 1222 Claude responded, "What if the single most damaging thing ever said to you about your joints was not just wrong, but wrong in a way that cost you years? What if the single most damaging thing ever said to you about your joints was not just wrong, but wrong in a way that cost you years? Not wrong like a small mistake. Wrong like a ceiling, built from assumptions nobody fully tested. There is a sentence spoken in examination rooms every single day, all over the world, in big cities and small towns alike. It gets delivered to people who came in hoping for answers. They walk out carrying something heavier than pain. They walk out with finality. The sentence is this: cartilage does not regenerate. Once it is gone, it is gone. Learn to manage it. If you have heard those words, I want you to stay with me right now, because what I am about to share is not false hope. It is not the kind of optimism that collapses the moment you examine it closely. It is something more serious and more meaningful than that. It is a peer-reviewed, institutionally published, direct challenge to the assumption behind that sentence. And it comes from one of the most respected research institutions on Earth. But before we get to the research, I need to give you something a single study cannot provide. I need to give you the full picture. Because a promising study without context is just noise. And missing context is exactly what most patients walk away with after every appointment. I am Dr. Andrade. Today we cover everything you deserve to know. What osteoarthritis is actually doing inside your joint, not the simplified version doctors give you in 12 minutes. What current treatments genuinely accomplish, and where they quietly fall short without telling you. What the Stanford medicine findings actually showed, and what they do not yet mean for your life today. And most importantly, what you should be doing right now, regardless of what future medicine eventually delivers. Because here is what every piece of research confirms. The patients who do best are never the ones who waited for permission. They moved toward the problem instead of away from it. Let us begin at the foundation. Your joints are engineering. Precise, load-bearing, friction-reducing engineering your body, refined over millions of years of evolution. At the center of that engineering is cartilage, a specialized tissue that covers the ends of your bones wherever they meet inside a joint. Its job is mechanical and remarkable. It absorbs shock. It reduces friction to almost nothing. It lets bones glide through full motion without grinding. When cartilage is healthy, that surface is smooth, firm, and extraordinarily resilient. Material scientists study it. Engineers try to replicate it. Nobody has fully succeeded. Osteoarthritis changes that surface. Slowly at first, then with increasing speed as the damage compounds and feeds itself. The reason cartilage has been considered impossible to regenerate is not arbitrary. It comes down to something specific in its cellular biology. Cartilage has almost no blood supply. Think about what that means for repair. Most of your body heals through the bloodstream. Cut your skin and blood floods the area with immune cells, clotting factors, and growth signals. Cartilage does not have that infrastructure. It is essentially cut off from your body's primary repair highway. The cells responsible for maintaining cartilage are called chondrocytes. They live in a low oxygen environment. They divide slowly. They are not built for rapid repair the way cells lining your gut or skin are. Your gut lining can fully regenerate in days. Chondrocytes operate on an entirely different timeline with far more limited resources. When significant cartilage is lost, the body sends inadequate resources. Those inadequate resources produce inadequate repairs, weaker tissue, disorganized structure, not the original. For decades, this led researchers and clinicians to the same conclusion. Cartilage degeneration moves in one direction only. Slow it. Manage the symptoms. Replace the joint when the damage becomes unbearable. But here is what the most recent research is beginning to reveal. And this is exactly where the story starts to shift. The assumption that cartilage cannot regenerate may have been less about absolute biological impossibility. It may have been about the specific conditions inside an aging, inflamed joint that actively prevent regeneration from occurring. Read that distinction carefully, because it changes everything about what becomes possible. If cartilage cannot regenerate because the cells are simply incapable, that is a closed door. You cannot open what does not exist. If cartilage is not regenerating because the biochemical environment inside the joint is suppressing a regenerative capacity that is still present, that is a locked door, and locked doors can potentially be opened. Think of it this way. You plant a seed and nothing grows. You could conclude the seed is dead and walk away. Or you could look more carefully. Discover the soil is wrong. The drainage is off. Something in the environment is suppressing growth that the seed is still capable of. Change the conditions. And growth that was always possible begins to occur. That is the direction the research is now pointing. And for patients told their cartilage will only ever get worse, that reframing is not a small thing. Now I need to slow down here, because most patients have a seriously incomplete picture of what is actually happening inside their joint as this disease develops. That incomplete picture leads directly to incomplete decisions about treatment, and incomplete decisions cost people years they cannot get back. Osteoarthritis is not simply wear and tear. That phrase does enormous damage. It implies a passive mechanical process, like a tire wearing down. Intervene in nothing. Wait for the tire to go flat. The reality is far more dynamic than that, and far more responsive to what you do and do not do every single day. When cartilage begins to degrade, it does not break down quietly. Fragments break loose inside the joint space. Small particles, molecular debris, byproducts of tissue losing structural integrity. Those fragments do not dissolve harmlessly. The joint's immune system recognizes them as foreign material, damage signals, and it responds. The structure that responds is the synovium, the membrane that lines your joint cavity. Under normal conditions, its job is producing synovial fluid, the lubricant that keeps joint surfaces gliding smoothly. When the synovium detects cartilage debris, everything shifts. It activates an inflammatory response. It releases interleukins, prostaglandins, and matrix metalloproteinases. That biochemical cascade produces swelling, heat, and pain. But most critically, it creates an environment that actively accelerates cartilage breakdown rather than protecting it. This is the part that fundamentally changes how you must think about this disease. The inflammation osteoarthritis produces is not just a symptom of damage. It is a driver of further damage. The joint has entered a self-reinforcing cycle. Cartilage breaks down. That triggers inflammation. Inflammation creates a biochemical environment that breaks cartilage down faster, which triggers more inflammation. The cycle feeds itself, and this is why two people with identical X-ray findings can have dramatically different experiences of the same disease. That inflammatory engine is not identical in every person. It is modulated by factors that vary enormously between individuals. Factors that are, in many cases, directly influenced by choices within your control. Your metabolic health matters. Adipose tissue body fat is metabolically active. It produces inflammatory cytokines. It elevates systemic inflammation, independent of any mechanical load. So, excess body weight contributes to osteoarthritis in two distinct simultaneous ways. It adds compressive force across the joint with every step, and it raises the baseline inflammatory environment the joint already fights against every day. Your diet matters. Chronic consumption of ultra-processed foods and refined carbohydrates elevates systemic inflammatory markers measurably. An anti-inflammatory dietary pattern does the opposite. The joint does not operate in isolation from your body's biochemistry. Your movement patterns matter enormously, and this is counterintuitive enough that it demands emphasis. The fear that movement accelerates joint damage is one of the most common and most counterproductive responses to an osteoarthritis diagnosis. Appropriate movement, structured, progressive, targeted, actually helps maintain the joint environment. It supports synovial fluid circulation. It maintains the strength of muscles that protect the joint from excessive load. It is one of the few controllable inputs that actually helps the joint manage its own environment. Immobility does the opposite. It allows protective muscles to weaken. It increases mechanical stress on the cartilage directly. It removes a key input the joint depends on. Your genetics also play a role. They influence how aggressively your immune system responds to cartilage debris. They influence baseline inflammatory tendencies. They influence how quickly the degenerative cycle accelerates once it begins. Understanding all of this, truly understanding it, transforms how you approach treatment. Osteoarthritis is a biological process. Biological processes have inputs. Some inputs are fixed, but more of them than most patients are ever told are directly modifiable. And modifying them is not a peripheral lifestyle suggestion. It is central to changing the actual course of the disease. One more critical thing about the progressive nature of osteoarthritis. Timing matters more than almost any other single variable. In the early stages, the inflammatory cascade is still modifiable. The joint environment can be meaningfully influenced. The damage has not yet compounded to the point where biology is operating largely on its own. In later stages, the options narrow significantly. The trajectory becomes harder to alter. The window for genuine trajectory change, not just symptom management, is widest early and closes progressively over time. Waiting is never a neutral decision with this disease, not at any stage. Now let me be direct with you about current treatment, because you deserve clarity that is not always offered in a standard clinical encounter. Current osteoarthritis treatment is primarily designed to do three things: reduce pain, slow progression, preserve function. What it is generally not designed to do is reverse or regenerate cartilage that has already been lost. That distinction is not discouraging. It is critical. Patients who understand exactly what their treatment is and is not doing use it far more effectively. Anti-inflammatory medications are the most commonly used tool in osteoarthritis management. They provide real, meaningful symptom relief. For acute flare-ups, for managing pain enough to engage in rehabilitation, they have genuine value. But they carry costs that are frequently underemphasized, especially for older patients already managing multiple conditions. Frequent or high-dose anti-inflammatory use carries real risks: gastrointestinal irritation and bleeding, elevated blood pressure, effects on kidney function, impacts on blood sugar regulation. In patients already taking multiple medications, the risk calculation around frequent anti-inflammatory use deserves careful, ongoing attention. They are a tool, a useful one in context, not a solution in themselves. Exercise and physical therapy are without exaggeration the most evidence-supported interventions for osteoarthritis at every stage of disease. The research here is not ambiguous. Appropriate structured exercise, particularly strengthening the muscles supporting the affected joint, consistently produces meaningful improvements in pain and function. It reduces mechanical load on the cartilage surface. It helps maintain the joint environment. It is among the most powerful things a patient can do, and it is also the most consistently avoided intervention. The reason is understandable. Movement causes pain. So patients stop moving, which weakens the protective musculature, which increases load on the joint surface, which accelerates deterioration, which causes more pain. The cycle feeds itself in the wrong direction. Breaking that cycle is not optional for anyone who wants to change their trajectory rather than simply manage symptoms. It is the single most important structural change most patients can make. Corticosteroid injections are among the most common procedures in orthopedic practice, and they deserve a more honest conversation than most patients receive. In the right situation, a steroid injection can provide meaningful short-term pain relief by rapidly suppressing inflammation inside the joint. For a patient too much in pain to engage with physical therapy, that window of reduced pain can be genuinely valuable, but only if that window is used productively. Only if reduced pain becomes an opportunity to build to advance a rehabilitation program that addresses the underlying mechanics driving damage. What steroid injections are not is a repeatable, indefinite solution. And here is something every patient who receives them should know. The evidence on repeated corticosteroid injections raises a concern not always proactively disclosed. Frequent injections may be associated with accelerated cartilage loss over time. The very intervention being used to manage the symptom of cartilage loss may, under certain conditions and with overuse, contribute to progression of the underlying problem. That is not a reason to refuse steroid injections. It is a reason to use them strategically, sparingly, and always as one component of a larger plan, never as the plan itself. Hyaluronic acid injections work on a different mechanism. Synovial fluid in an osteoarthritic joint changes composition. It becomes less viscous, less effective as a lubricant. These injections aim to supplement that environment. The clinical evidence is genuinely mixed. Some patients report meaningful improvement, others notice minimal benefit. For selected patients with mild to moderate disease, it can provide a useful period of improved comfort. But it is not a substitute for the structural work that actually changes long-term trajectory. Platelet-rich plasma therapy PARP has moved from the fringes of sports medicine into increasingly serious mainstream consideration. The rationale is biologically sound. Platelets carry growth factors that may help modulate the inflammatory environment and support tissue repair. Concentrate them. Inject them back into the affected joint. You may create conditions more favorable to the joint's own maintenance processes. International orthopedic consensus statements have acknowledged PARP as a reasonable consideration for selected patients, specifically those with mild to moderate knee osteoarthritis who have not responded adequately to conventional management. What the evidence does not support is calling PERP a cartilage regeneration treatment or a reliable guarantee of improvement for every patient. I want to tell you about a patient, because his story illustrates something that no amount of research summary can fully capture. Raymond was 61 when I first saw him. He had been managing right knee osteoarthritis for 4 years. In those 4 years, he received 3 corticosteroid injections. Each injection was followed by a few weeks of meaningful relief, then a gradual return to baseline pain. He had been told PERP was the logical next step and arrived ready to pursue it immediately. When I reviewed his full history, something became immediately clear. In 4 years of treatment, 4 years of injections, and follow-up appointments, Raymond had never completed a structured physical therapy program. He had been injected 3 times. He had never once been given a plan that systematically addressed the strength deficits and movement patterns, placing excessive mechanical stress on that joint every single day. We started there, not with an injection, with a program. A structured, progressive rehabilitation plan built specifically around his functional deficits and the mechanics of his knee. Targeted, measurable, consistent, within 5 months, Raymond's pain scores had dropped significantly. His function had improved to a level that made PERP a secondary consideration available if he wanted it, but no longer the urgent necessity it had seemed. The injection was still there as an option. What he had needed first was the plan around it that nobody had ever built for him. Raymond's story is not exceptional. It is, in my experience, far more common than it should be. The interventions exist. The evidence exists. What fails patients is not the availability of good treatment. It is the coordination of that treatment into a coherent strategy that addresses the underlying problem rather than just the immediate symptom. Now let us talk about the research that has genuinely changed how the field is thinking about this disease. In late 2025, scientists at Stanford Medicine published findings that generated significant discussion in the arthritis research community, and for genuinely good reasons. The study focused on a specific enzyme called 15-PGDH and its role in cartilage aging and degeneration. In animal models, and this qualifier matters, so hold it carefully. Inhibiting the activity of 15-PGDH produced signs of cartilage regeneration in aged and injured mouse joints. The animals in whom this pathway was blocked showed structural evidence of cartilage repair. They also demonstrated reduced pain behaviors compared to control animals that did not receive the intervention. Why does this matter so significantly? Because it directly challenges one of the foundational assumptions shaping osteoarthritis research and treatment for decades. The assumption that cartilage degeneration is a one-directional process. That once breakdown begins, the biology has no meaningful capacity to reverse course. What the 15-PGDH findings suggest is something fundamentally different. There may be active molecular mechanisms in aging and diseased joints suppressing cartilage regeneration, not eliminating the biological capacity for it blocking it. And those mechanisms may be specifically targetable. Inhibit the right enzyme, remove the specific molecular suppression, and the joint's own biology may begin doing something it was prevented from doing. Rebuilding, that is a different research question from anything that has driven this field for decades. Not how do we slow the destruction, but can we remove what is preventing the repair? Now I want to be completely clear here, because overstatement on this point does real harm to real patients. This is not a human treatment. It is not available in any clinic anywhere. It has not been tested in human subjects through any clinical trial process. The translation from animal models to human treatment is long, complex, and frequently unsuccessful. The history of medicine is full of promising animal studies that did not survive contact with the far more complex biology of human subjects. None of that means this research should be dismissed. Dismissing early research is exactly how promising directions lose momentum. It is how patients wait 15 years for treatments that could have moved faster with the right attention. What it means is this: hold the finding with appropriate seriousness. The science is pointing somewhere genuinely new. The direction of that pointing matters profoundly. And for patients told with complete certainty that their cartilage will only ever deteriorate, the emerging research landscape suggests that certainty was always more assumption than established fact. Let me bring everything together into the only place that ultimately matters. What this means for you, today, in your actual life. The conventional framework for osteoarthritis was built on the assumption that cartilage biology was fixed and irreversible. The 2025 Stanford research is one of several converging lines of evidence suggesting that assumption deserves serious reconsideration. That does not mean cartilage regeneration is available to you today. It means the ceiling placed over every osteoarthritis patient is less certain than it once appeared. What does not change is what you should be doing in the meantime, starting now. If you are carrying excess body weight, the evidence for weight reduction as a joint protective intervention is as strong as anything in the field. Every excess pound applies multiple pounds of additional compressive force across the knee with every single step. Reducing that load directly changes the mechanical environment your cartilage lives in every day. It also reduces systemic inflammatory markers. The metabolic and mechanical benefits compound each other simultaneously. If you are sedentary, that is the most important thing to change. Not the most comfortable thing. The most important. Appropriate exercise consistently outperforms inactivity in every meaningful outcome measure. Pain, function, rate of progression. The fear that movement makes arthritis worse is understandable, pervasive, and almost always counterproductive. Movement done correctly is protective. The body you do not use deteriorates faster than the one you challenge appropriately. If you are receiving injections without a structured rehabilitation plan surrounding them, you are borrowing relief without building anything more durable. The window of reduced pain an injection creates is genuinely valuable, but only if that window is used to build strength and movement quality that changes what is happening mechanically every day long after the injection's effect has faded. If you are taking anti-inflammatory medications regularly, make sure the risks are part of a conscious, ongoing conversation with your physician, not an assumption that because they are available over the counter, they are without consequence. And if someone has told you your cartilage cannot regenerate and nothing remains but waiting for a joint replacement, hold that statement more loosely than it was delivered. Not because cartilage regeneration is available today, but because the science is actively evolving. The assumptions behind that statement are being directly challenged by credible research from credible institutions. The certainty with which it was spoken was never fully warranted. The patients who will benefit most from the next generation of osteoarthritis treatments are not the ones waiting. They are the ones who arrive at those treatments having protected their function, their strength, and their joint health as carefully as possible in the years before those treatments become available. They are the ones who did not lose ground they did not have to lose. That is your work right now. Not passive management. Not waiting for a ceiling to lift on its own. Active, intelligent, evidence-informed protection of what you have. Because what you preserve today is exactly what determines what becomes possible tomorrow. The science is moving. You should be too. Everything discussed here is based on published research, clinical evidence, and peer-reviewed findings. This is educational content and is not a substitute for personalized medical advice from your own physician or orthopedic specialist. Osteoarthritis is an individual condition. Please consult your healthcare provider before making any changes to your treatment plan.